and welcome back to another episode of the Core Consult RX podcast. My name is Mike Corvino. With me, as always, Cole Swanson. Cole, what's up, man?
Doing great. Memorial Day Core Consult RX podcast.
Special edition.
Special edition.
And by special edition, we mean, well,
regular edition.
Pretty much basically the same podcast.
The hide and cover from the incoming tropical storm podcast.
Yes.
Maybe we should do some, some readiness, some preparedness advice. We should have done that.
If anyone is qualified to talk about that, I think it's definitely us.
Probably us, right?
We are basically like survival experts when it comes to
Hey, we've evacuated. I don't know if you evacuated. I've evacuated like twice in the last few years, I feel like.
I didn't. So that was one of those idiots on the news. It's like, I'm going to stay here and ride it out.
Surfing on the nasty sewage water as it's filling up Charleston.
Yep, that was more my style.
Right.
I didn't do that, but I did stay behind.
Yeah.
And luckily, it ended up, at least where we were, not being as bad as they originally had projected.
Yeah, surfing in the sewage water, not recommended.
Yeah.
Which, by the way, I see a lot of people evacuating Florida, but apparently there was some really bad flooding in Maryland, like today.
Really?
Really bad. Yeah, It's flash flooding. I don't know. Not Florida, but...
Yeah, Florida's been hit a lot lately. It's been rough.
The Gulf.
Anyways, back to your weather. You hadn't talked about the weather in probably a couple episodes.
I know, it's been a little while.
And it's been eating at you, I can tell.
I know, we got a tropical storm coming. I can't talk about it.
Yeah, you can't not talk about the weather.
I don't remember the name of it, though. You don't know it, do you?
Not a true weather fan. No. I do know it. I'm just not going to tell you.
Dang, suspense the whole time.
The whole time.
So what are we talking about?
So this is how today's preparation went for the podcast. We sat down about 5 minutes before we were supposed to record, and we were like, what do you want to talk about? I have no idea. What do you want to talk about? And so we're just going to kind of
we're going to talk
freestyle today.
Yeah, we usually do a little more preparation, but maybe we actually did take a little break today because it was Memorial Day.
Yes,
or did we not take breaks?
No, we took a break. I'm not going to lie. I took a little bit of a break today.
Good.
But yeah, we are going to talk about some general depression. We've talked about this a little bit probably in the past.
Just touched on it.
But we're going to run through some general depression treatment guidelines, things like that.
Focus on STAR-D trial and kind of what it showed us, and talk about the difference between, we'll mainly be focusing on what you would do in the primary care setting, because if you've had a psych rotation or if you work in psychiatry, they do a little bit different stuff because they know what they're doing.
Yeah, they're the experts.
They're the experts. So we'll focus on STAR-D and kind of where first line major depression treatment goes. But before that, we're going to talk a little bit about evidence-based medicine in general, right?
Yeah. So I just went to a evidence-based medicine conference here in Charleston, South Carolina, put on by Dr. Wainwright, Dr. Scott Bragg. And they basically have speakers come in from all different areas. Its main audience is primary care physicians, pharmacists, nurse practitioners, and PAs. But they bring in all kinds of different speakers from different areas of specialties. And we'll go over, different trials, evidence-based medicine, aspects of each type of disease state. And one of the big things that kind of has come up while I was kind of watching this conference and then talking with people afterwards, or seeing how people would answer questions, is basically, is evidence-based medicine really all that important? Why do we talk about it? Why is it a term that we even use? And then how do we actually apply it to our daily practice, if you will?
Yeah. And speaking of why is it a term, it actually is not an old term. It's very new. Even though evidence-based medicine, or the idea behind it, is not a new concept. We've always wanted to treat patients, not always, I should say. In the era of modern medicine, we want to treat patients based on something that we have seen in some type of experiment or some type of study that it works. The term evidence-based medicine was coined really by JAMA, or in JAMA. It showed up in JAMA in 1992, and the guy who coined it, his name was Gordon Guyat. And so it's relatively new. It was in an article called The Rational Clinical Examination. Before that, there were people who were obviously practicing it and pushing it forward, but that actual term, EBM, was coined only about, 26 years ago or so?
Something like that.
Yeah, it's older than me.
You just let on how young you were.
I know, I got to throw it out there. I don't want people to know, so.
I'm also that young.
Forget I said that.
I'm also 25.
Also. Yes, exactly.
Anyways, but yeah, I think that it's something, it's interesting to me because, and I've run into this with clinicians who have been practicing for a long time. They've been very successful in their practice. But, sometimes I've noticed that they've sometimes resort to treatments that they've just always done. The biggest, I guess, example of this I can use is hydrochlorothiazide. All right, and there's probably some of you listening that go, yep, you use it all the time, dispense it all the time for the pharmacists out there. But is that the best, I guess, option if you're going to use a thiazide diuretic?
Right.
My
pressure. Yeah.
My argument would be no. And I like this argument because we actually have a lot of data that backs it up and shows an example of why we should be using evidence-based medicine.
And why we should be using alternatives, because there's a distinct lack of evidence when it comes to HCTZ, right?
Right, exactly. So I guess starting off, if we'll use the example of the ACCOMPLISH trial, which you've probably heard us talk about. But one of the things that the ACCOMPLISH trial did is they took a group of patients, they gave them, all of them got benazepril, the ACE inhibitor. And so one of the questions that I'll get from my students or from other practitioners is, what is our next add-on therapy? Like, what's our next, drug that we're going to add on? And so what this trial looked at was they took benazepril and added on HCTZ for one group, and then they added on amlodipine to the other group, and then compared them head to head. Now, I know when I first started hearing about this study, like when I was in school, I kind of assumed that the amlodipine benazepril, because I would hear people say that's a better option.
Mm-hmm.
I just assumed that they lowered the blood pressure to a greater extent, and that's why we got some of the results that we do. But what we realized when we actually compared the two groups is that we didn't have a difference in blood pressure lowering. And so to me, that's one of the biggest, important factors of this study, because one thing that I'll hear is, well, as long as we're getting the blood pressure lowered, what does it matter?
Right.
Right. I mean, if I give them...
I think that's a really common thing for people to assume, in physiologically speaking, it makes sense.
Right.
So it comes down to other aspects of the drugs that are separate from just blood pressure lowering that we may not be aware of, or we are, and they just play a different role than we traditionally think, right?
Exactly. And so in the case of ACCOMPLISH, what we saw is that the amlodipine combo had a greater reduction in the primary outcome composite that they were looking for. So cardiovascular events, so non-fatal MI, non-fatal stroke, and CV, death from CV causes. And so that was significantly different with a number needed to treat of 45, which is great.
Yeah.
Then when we kind of break that apart, look at some of the individual differences, we saw that fatal and non-fatal MI was significantly different. Revascularization was lowered. We also have secondary outcomes, such as looking at death from cardiovascular causes plus non-fatal MI and stroke. So another composite that was shown to be significant. And then composite of cardiovascular events, which is a whole huge list of things, also significant as well. And so the takeaway for me anyway is that, yes, you are getting the same blood pressure lowering with either agent, but what did you actually achieve in the long run? Because I always say treat the outcomes, and when I say me, I mean a lot of people, not just me. But I always invented this term. But I'll typically say to students, treat the outcome, not the number.
Right.
Because what good is it if we get the patient's blood pressure lowered in clinic and it's low and they're on the surface good to go, but 10 years later have a fatal MI.
Right, because why do we treat blood pressure in the first place? Not just because they can say, oh, my blood pressure is lower and I don't have a headache or whatever. It's to prevent really primarily cardiovascular outcomes. There's a lot of other things that can happen, but cardiovascular is the main thing. So in ACCOMPLISH, all these patients were high risk for cardiovascular events, 50 to 60 and two big risk factors, or over 60 years with at least one big risk factor. Those being diabetes, so this included diabetes patients, heart failure, peripheral artery disease, CKD, previous CVA, or acute coronary syndrome, any of those that are putting these patients at high risk. So specifically in that patient, which there are a lot of them who also have hypertension, this is where you really want to consider where we're going to get the best decrease in events long-term when it comes to the heart. And it looks like HCTZ is not really getting us there.
Exactly. And, the other thing is HCTZ really doesn't have any good outcome data, period.
No.
They've never really used that one in combination or alone to show that it can reduce cardiovascular events. We know that it obviously lowers blood pressure.
Yes.
However, again,
which some would argue not very well also, but others would say they've used it all the time and it of course lowers blood pressure. But
and I think that one of the arguments that I'll hear is, well, if we know what causes things like heart failure and put you at risk for things like stroke and MI is an elevated blood pressure over time. However, that still doesn't account for studies like this one and others that show that if you use an evidence-based medication, it can change the outcome. So it's blood pressure lowering, but there's also something else going on with the mechanism, like Cole was saying, that is playing a secondary factor that is helping reduce these events. And if we look at like the primary outcome, for instance, for Accomplish, there was an event percentage of 9.6%. So 9.6% of the patients in the amlodipine combo had an event. 11.8% had an event in the HCTZ group. When we're looking at that value, it doesn't seem all that impressive, right? Not still a low percentage in both groups. So I'm not saying if you are treating with HCTZ, you are necessarily the worst person ever and not doing your job. That's by no means what I'm saying. However, when we look at number needed to treat and we see that we have a number needed to treat of 45, if you think about 45 people to prevent one extra event, whether that's fatal or non-fatal at all, that's
less than 2 days of clinic.
Yeah, I mean, if you look at how many people are being treated for blood pressure, I mean, that's crazy.
Significant,
yeah. I mean, you could be, if that was a scratch off, you'd be playing it all the time.
Right. And I think it goes to a bigger point too, that of course HCTZ, it's not like it does nothing. It does something. It lowers blood pressure, which is good. That's better than having high blood pressure. And it may decrease events as well. We just don't have data saying that it necessarily does, especially not that it does better than something else like the combination with amlodipine or even with a different thiazide diuretic. So, the argument really is it's cheap, and that's the argument for a lot of these medications that will be prescribed very commonly. It's because they're cheap and we've been using them for a long time. But it's worth looking into other options, especially in this instance, because there are other cheap thiazide diuretics that may be better alternatives. And we've definitely talked about this before, but potentially indapamide is on the $4 list at a lot of places, and then chlorthalidone is reasonably cheap as well. Would be a reasonable alternative, or just using amlodipine, which is really almost just as cheap as HCTZ. So something to consider.
And the other thing to consider too that's kind of interesting is we only dose amlodipine. Most people only dose it once a day. But if we actually think about like the half-life or even the duration of how long the drug lasts, the half-life is only, they give a range if you look on like Lexicomp of like 6 to 15 hours. Usually we think of it being about 12 hours on average. It's one of those things that if we're going to dose it according to the half-life, you really would want to give it at least twice a day anyway, which we almost never do. Now, things like chlorthalidone and indapamide have much longer half-lives. Chlorthalidone has an even longer half-life than 24 hours. Indapamide's right about 24. But, it's kind of interesting that we don't ever dose to the half-life with that agent.
Yeah. That comes up frequently with blood pressure medications, right?
Yeah, well, and like things like an ACE or an ARB, so like lisinopril has a 12-hour half-life as well. Yeah. But the duration of the effects lasts a little bit longer.
Right.
And so we can kind of get away with it. But there are some people that I've seen dosing it twice a day. Valsartan, for instance, is an ARB, often gets dosed once a day, but it's only been studied twice a day, which is kind of interesting.
Yeah.
If you look at any of the clinical trials, it's listed as being twice a day.
Yeah. Metoprolol tartrate, some people dose that once a day.
Yeah, I've seen that too, which that doesn't make sense at all.
Yeah.
But yeah, and there's just definitely times where we're not using the kinetics. And I'm not saying that there's never a reason for that.
Right.
They may be very specific.
There's always exceptions to the rule.
There is. But I will say that HCTZ, just without the evidence to back it up as far as the risk of reducing an event in the future, I don't see a purpose when we have all these other agents available to use it in the first place.
Yeah, it's because, like you said, there's other options. If there weren't any other options, as far as if you just really want a diuretic class in there, but there are. there's
There
other
are.
options.
Some of the things like All Hat has showed
Yeah.
benefit with chlorthalidone.
Right. As a
We've
single
also,
agent
right.
compared to ACE and
Shep, we've also
Yep.
seen in elderly patients benefit with chlorthalidone. For indapamide, we have High Vet, which
Mhm.
was studied in veterans 80 to 100 years old.
elderly patients. Yeah.
And then also we have like Progress,
Yep.
which was
Post-stroke.
post-stroke, and
Yeah.
that showed a benefit when you add indapamide to an ACE inhibitor,
Right.
that you have benefit post-stroke. So there's always these big trials that have been done that shows that these have evidence versus HCTZ, which doesn't have that.
Yeah.
So I just think that it's definitely an interesting debate and something I'm surprised at. If you can give somebody something that's evidence-based, why stick with HCTZ?
And I'm sure another reason is because it's in combination with so many things. Super easy to just prescribe a cheap combination pill and they only have to take one thing. It's very enticing.
Mm-hmm. That is
granted,
true.
Lotrel is cheap and it's also a combination, but
Right.
I can see the draw of that.
Yeah, that's true. I can definitely see that as well. But, I would argue that it would be worth having the conversation at least with the patient, because the indapamide's a very small pill.
Yeah.
And, it'd be worth at least bringing up see if they're willing to take two different medications. And then maybe even you can split up the timing of them as well if you wanted to get real evidence-based.
Mm-hmm.
And maybe dose the ACE inhibitor at night for those potential non-dippers.
Mm-hmm.
And get real fancy with it.
Yeah, a little Mapec trial.
Yes, Mapec. That's also how they dosed it for Hope.
Yeah.
And Micro Hope,
Yep.
when they dosed the Ramipril, dosed it at night. The RAS system is more active at night.
Mm-hmm.
So maybe more effective to give the ACEs and ARBs at nighttime and give the other ones in the morning.
Dropping all sorts of evidence-based tips now.
Yeah, rapid fire.
Rapid fire. Better have a pen and pencil ready. Pen and paper and a pencil.
Yeah, exactly.
All of them.
All of them. Number 2.
Number 2.
Number 2 pencil. They still have like
I
numbers.
don't know.
in
I
pencil?
think a lot of the mechanical pencils have number 2 lead.
I would think.
That's what they've said. Even though on like standardized tests, you have to have the actual yellow number 2 thing.
I wonder what.
Well, I did when I was a kid. I guess they use computers now. Maybe I am old.
Back when I took the SAT.
Right.
Yeah,
No, that's true.
It's been a minute.
Yeah, been a little while.
Yeah, I'm glad. I don't want to take the SAT right now.
No.
Probably wouldn't do too good.
I'm about to take a standardized test, which I do not want to take.
Yeah.
But anyways. So yeah, that the accomplished trial, really good example of the importance of evidence-based medicine and how to, which this is a particularly new trial. It came out in 2008. We talked about All Hat. That was 2002. So the evidence, it's been there. It just takes a little while to get disseminated and for people to change practice if they think it's worth changing practice. We've talked about, I think podcast numero uno was the ACC/AHA guidelines, and they're preferring chlorthalidone as the thiazide diuretic of choice in their guideline, which is, in a lot of ways based on kind of what we talked about.
Mm-hmm, exactly. And the other thing is I stumbled across this the other day, but I was looking at Up to Date and looking at the authors of the resistant hypertension article that's on Up to Date. I was looking through some of their stuff, just looking to see what they added on as fourth line agents, and they were saying one of the first things before they even add a fourth line is that they will change HCTZ to chlorthalidone or indapamide.
Yeah.
Is one of their first things that they do. I need to go back and see if they also put that for regular primary hypertension.
Right.
But I thought that was pretty interesting that even they're acknowledging the importance of the thiazide, one being significantly more effective than the other.
Yeah.
What else? Should we give another example of something or move on?
I think that was a great example. We can move on to depression, but I mean, evidence-based medicine, it's there. That's what we did. I mean, that's the whole reason we started this podcast, isn't it? The whole reason we come on here and yap a little bit.
Plus, we really like hearing ourselves talk.
Yeah, we love it. It's great.
No, but in all seriousness, that is definitely why we kind of brought it up, because I wanted to be able to talk about it in a practical sense. And I'm just really, really surprised of how many people don't care about it, or I guess are just not familiar with these big landmark trials.
Yeah, and it's not a knock against them. There's all there. I mean, because especially physicians, everybody likes to knock physicians, but they have just an immense amount of things that they have to be concerned about. So that's why hopefully pharmacists and other providers can be there to show them what evidence is coming out and, maybe help them along.
And if not, hopefully we'll cover it on the podcast.
Right.
And you guys
and
will.
then just every physician in the country will be listening to our podcast.
Literally everyone.
Every single one.
We're huge.
Come on. What is that? American Academy of Physicians?
Yeah, put us on.
Put us on.
Yeah, no.
No.
We tried. They said no.
They said no.
All right, so talking about general depression.
Yep.
Definitely something that is. So you will deal with this at some point or another if you're in, especially if you're in primary care.
Oh, yeah.
And like Cole said at the beginning, we're going to kind of go over this in a way that is geared more towards, primary care, family medicine type things. We're not obviously speaking to someone who's a psychiatry expert, because
I know they like to start with some different things of what STAR-D might say, and they take a lot of other factors into account. But
yeah,
I think this is a reasonable guide for stepwise approach to treating general depression.
And before you even get to the treatment part of it, one thing that I think is important, especially in a primary care setting where you may not be as familiar with seeing these patients that are clinically depressed day in, day out, but using some sort of a way to quantify this, I guess, ranking of depression, or if the person is depressed in the first place. That's one thing that I've seen a lot of places will not do is, they'll talk to the patient. The patient says that they, have symptoms of depression. They get started on an antidepressant, and then that's kind of that. They just ask the person from then on out how you feel, things like that. But having one of the questionnaires that we have available to us, I think is really a really good way of quantifying the progress or lack of progress and figuring out when we need to augment or replace or whatever we need to do.
Mm-hmm.
The one I like a lot is PHQ-9, and that was put out by, I believe, Pfizer has the copyright on that one.
Yeah.
I have to double check for sure, but that's available as well. PHQ-9 is basically 9 questions that the patient can answer, 0 through 3, 0 being not at all, and then 3 being nearly every day. And then they will total up their answers, and then they get a grade at the end to see how severe the depression is. It's something that you can give a patient in the very early stages. There's also a PHQ-2, I believe it's called, which is 2 questions, and that kind of helps to go through the questions and see if the patient has any signs of early depression. From there, you can go on to the 9 if you have some suspicions. But this is something that needs to be given to patients so that they can answer these questions and give their opinion without having to just arbitrarily describe how they're feeling, and also as a way to record progress.
Right. And the PHQ-2 is easy. You could even, just ask them to kind of the 2 questions, which is, are you having little interest or pleasure in doing things, your normal things, and are you feeling down, depressed, or hopeless? And they'll rate it on a scale from 0 to 3 if you actually hand it to them. But it's a very easy way to gauge it and see if you wanted to do the full PHQ-9 and diagnose them and pursue treatment. And we're going to talk about, we're going to focus really specifically on treatment today, when usually we'll do like more of an overview talking about symptoms and things. I do just want to mention that cognitive behavioral therapy is a very important part of treatment, which is recommended in almost all instances. But we realize that it is incredibly hard to get patients to follow up with CBT and psychotherapy of that sort. It helps in a lot of disease states, especially when it comes to psychiatric disease states, but patients just do not follow up. They want a medication. So anything you can do to encourage them in that way would be helpful.
Right. All right. So jump into STAR-D.
Let's do it.
All right. So STAR-D is actually a really cool setup, the way they brought these patients in, and they had organized 4 different steps of therapy.
Mm-hmm.
They would start with the step. They would see who would get to remission, and then if not, they would either move on to step 2, or and reevaluate and move on from there. And the patients who reached remission then were just monitored from there. But it really does paint a good picture for those of us who are not psych experts on where to kind of take things if the person is not seeking out a referral.
Right.
So what they did is they started off with citalopram.
Mm-hmm.
So everyone got citalopram, SSRI, and were then assessed to see if they met remission just on that drug.
And if you've heard SSRIs being first line for major depression, a lot of that is based on this trial, starting with that.
And the other thing is, I like that. It doesn't have to be citalopram.
No,
if they have some sort of a arrhythmia where we would be worried about a prolongation of the QTC interval, that's not as huge of a deal as some other drugs. I think sometimes pharmacists paint it as a bigger picture, bigger deal than it really is. But if they're on multiple drugs that can prolong the QTC interval and they have, history of something that would be a adverse effect to watch out for and be aware of.
Yeah, definitely if they have a history. And the biggest thing is just hopefully the physician is monitoring EKGs every once in a while to see if it's prolonged or if they're concerned about it.
But the big thing with depression that I think is interesting is you really, really have to look at patient-specific factors.
Mm-hmm.
So, for instance, if you had a patient that is, let's say, you're very worried about non-adherence because you can't get them to actually follow up. Maybe they skip several doses of their medication throughout the month. You'd be really worried about someone like that if you're skipping, especially multiple days in a row of an antidepressant, them falling into like discontinuation syndrome,
right? Especially with SSRIs,
right? So in that particular patient, I would really recommend using something like fluoxetine.
Mm-hmm.
It's got a 9-day half-life on it, and there is no like titration period or anything like that. So that would be one that I would shoot for that particular patient, because then you wouldn't be worried if they do stop it, them having exacerbating symptoms, discontinuation syndrome, whatever.
Right, and that's in stark contrast to paroxetine or Paxil, which many consider worst in class as far as the SSRIs go. It has the most side effects, the most drug interactions, the worst sexual dysfunction. It's pregnancy category D, if we're still allowed to use those categories, as opposed to the rest, which are category C. It's got the shortest half-life, so it has the worst discontinuation syndrome. So yeah, if you don't have to use it, we generally try to stay away from Paxil if we can.
And if you have a patient that, let's say, has cardiovascular disease in the past, especially patients that have like a history of acute coronary syndrome or MI, we could potentially use sertraline in those patients. We have evidence from SADHART from back in 2002 that shows that it's safe to use in that patient population post-MI. And, that's another one we could potentially use, and that STAR-D also used in their step 2 approach.
Yep.
But, definitely looking at it from a patient point of view, very patient-specific, is really important, because there's not any good evidence that shows that one is going to work better than the other for every single patient.
Right.
That's almost never the case in psych meds.
Right. Now, if they do reach remission, the idea is to treat for about a year, and I think the recommendation for that comes from STAR-D as well. They did a 12-month follow-up, saw how they were doing, and potentially taper them off the antidepressant, because like a lot of the things we've talked about with GERD and other disease states that aren't necessarily chronic, if you don't have to, you can, if you don't have to keep it on forever. The other one I was thinking of was insomnia. You can taper them off, and it's really just for a time. It's not meant to be forever unless they have recurrent depression.
And the other thing would be is titrating these patients up to a proper dose.
Yeah.
So for instance, like sertraline, 200 milligrams is the max, the kind of the gold dose. And you see a lot of patients stopping at 50 to 100, and then they may be having other medications added on to that or being switched because they're not working. If the patient can tolerate it, we probably should be maximizing the doses to where they've been studied at.
Yeah, because they are reasonably safe, especially SSRIs. There are some drug interactions. I mentioned sexual dysfunction, which I think is important to mention to patients, because if they don't realize that's a side effect and something like that starts happening, then they're probably going to stop it, and they're at risk for discontinuation syndrome. One that's lower risk for that would be Wellbutrin, and we'll talk about that in the follow-up steps. But for the most part, these are considered pretty safe and pretty effective medications.
Exactly. So we want to take over step 2?
Sure. So yeah, step 1, generally start with an SSRI. And like we said, in other psychiatric settings, they might start with something else, or Remeron, or even Wellbutrin, or an SNRI like Effexor, depending on the patient. But if you're following STAR-D, they would just go with an SSRI for a regular patient if it fit them. Step 2, they would either augment or they'd switch. So they would either add on to the citalopram, bupropion, buspirone, or cognitive behavioral therapy by itself, or they would completely switch to a different medication, either bupropion, sertraline, Effexor, which is venlafaxine, or just cognitive behavioral therapy. And they saw some really good results from these first two steps. In step 1, there's about a 37% rate of remission, which was higher, statistically significantly higher than step 2, where they saw about a 30 to 31% remission rate with those treatment regimens. So that's pretty solid.
Absolutely. And it's interesting too, like with what they use as far as the augmentation. So like bupropion, for instance, with citalopram, you're covering the serotonin aspect. Bupropion, it's a weak inhibitor of norepinephrine and dopamine. So you're covering your 3 neurotransmitters that we most likely think of when we think of depression. And so you're covering your basis with those 3 drugs. Also, the buspirone is working on serotonin as well. It also has some dopamine receptor binding activity, but you're working on from a separate pathway, if you will. And then CBT obviously is completely separate than medication altogether. But they've tried to augment with these drugs that would hopefully enhance, I guess, the effects and enhance the likelihood of reaching these outcomes, these neurotransmitters that were potentially low by giving different drugs. You most likely wouldn't see like 2 SSRIs put together, things like that.
For risk of serotonin syndrome.
Right. The other thing is this is another aspect of where these questionnaires would come into play. Because let's say you gave someone a PHQ-9, they scored really high, meaning that they're depressed, and you see some decline in that score, but not quite to the point of remission. That may play an argument into whether you should be augmenting or stopping the medication. Right. Because if you're seeing improvement, but just not as much improvement as you wanted to, that would probably be a case for keeping on the current therapy and then adding on to that. Versus if you're on citalopram, let's say, you see 0 difference whatsoever, probably a good idea to go ahead and switch.
Switch it up.
So that's another thing that the questionnaires really do play a role in if you're not seeing these patients on a daily basis.
Right. Or if they're having undesirable side effects. So SSRIs can cause a little bit of weight gain. And if that is something that's going to cause this patient to stop taking it, you might go with something that's more weight neutral, like bupropion would be a reasonable option in that case.
Right. Did you go over the 4 switch strategies?
Yes.
Okay. So after that, those didn't work. They were switched to step 3. They had 2 augmentation strategies in step 3. The patients could stay on whatever they were on currently and then have either lithium or cytomel T3 added on to as well. And then for switch, they could be switched to neither nortriptyline, which is a tricyclic antidepressant, or mirtazapine. And then again, step 3 had a remission achievement rate of about 13.7%, and also completely separate types of classes of medications in both groups, augmentation and switching. So kind of interesting on that.
I feel like they really started pulling stuff out of the hat here. So lithium, it can be used for augmenting major depression. Starting to use T3, there's some evidence behind thyroid hormones, but that would be kind of interesting. And then the TCAs are known more for their side effects. So I guess maybe a third line. I would probably be in favor of trying a few different combinations with potentially safer medications before going to that. But Remeron is definitely a reasonable option. A lot of people will try that first line for a few reasons. One, it's dosed at night and frequently helps people sleep, which if you get patients' depression under control, hopefully that will improve their sleep, just generally speaking. But for somebody who has really refractory insomnia, that could help. Also for patients who weight gain is an issue as far as they're underweight. So you want them to gain weight. Remeron will increase appetite, and that might be a consideration in that patient who's skinny, potentially has a history of anorexia. You might consider Remeron in that patient.
Yep. And kind of going back to step 2, if you have a patient that is overweight, that's trying to lose weight but having a hard time doing so, bupropion may be a good option for that patient. For those of you who don't know, bupropion is one of the components of Contrave, the weight loss medication. Yep. So it does have some weight loss data, and probably a good option for someone like that. But yes, mirtazapine definitely for gaining weight would be good.
Right. And then they would go to step 4. So the last step, if the patient was still refractory, they had a similar, about 13% efficacy rate with this, but they'd go with tranylcypromine, or the combination of Effexor and Remeron, which isn't there a street name or common name for that combination?
So I don't know how
You knew that?
unique this is or how just completely slang and never use this. I don't hang out with the psych people enough. We'll have to ask one. But California rocket fuel is apparently the slang term for using venlafaxine and mirtazapine together.
Sounds good to me.
It definitely has a cool ring to it. But yeah, I looked through real briefly some forums and things like that online, and there's definitely a lot of people that are referring to it as that. I'd be curious to see how often that's used, or that term rather is used in clinical practice, but definitely is a good option as well, and seem to help the patients in the STAR-D trial.
Yeah.
About 13% of patients who had not reached remission from the first 3 steps got to remission after using step 4. So all in all, you're looking at about 2/3 of these patients reaching remission with one of the options that were given.
Augmenting, switching, adding on stuff. It's very patient specific, just like bipolar. So this is unipolar depression that we're talking about today, but bipolar depression is similar, or bipolar disorder in general is similar. You don't know what's going to work. You try a lot of stuff until something works. The only difference with major depression is that hopefully it doesn't have to be lifelong. You may be able to titrate them off of it.
And the other thing is this is only a skeleton. There's so many different options we use now. Antipsychotics.
A lot of new stuff coming out. New SSRIs, new SNRIs.
So it's definitely something that there's a lot of options. But I guess what I like about this is, one, thinking about whether you need to augment or switch, thinking about the mechanism of action, thinking about the
side effects,
pharmacokinetics and side effects of these drugs to see how they can interact and how they can be patient specific, and really understanding the true pharmacology of these meds is super important. And then not just for drug interactions but all that, but really for actually helping the patient meet remission. You don't want to think about these drugs as, oh, it's an SSRI, they're all the same,
right?
Because they're very much not,
right?
Kind of like our hypertension meds, like thiazide diuretics that we mentioned.
Bringing it all back around. Planned that perfectly. Yeah, it was all intentional. But that's really important, is looking at these drugs. We know drug classes, but don't look at them as a class in and of itself that they're all interchangeable. Really agent specific for the particular patient. Yeah, there's actually a million examples of that. Fluoroquinolones would be a good example. Some cover different things. Some penetrate different parts of the body. Yeah. Some have different side effects than others.
Yeah. And I think with antibiotics, it's one thing. I think a lot of times people can get their heads around that,
it's
but
that covers Pseudomonas, but this doesn't cover Pseudomonas.
Right. And that's definitely a hard thing for students to learn. They're okay, well, carbapenems, but we know ertapenem doesn't cover Pseudomonas. So something like that could be just pure memorization. But looking at hypertension, dyslipidemia is another one with statins. Not all statins are created equal.
Or even dyslipidemia drugs in general. It's not all about getting the numbers down.
Right.
The statins have something that they do more than these other drugs that helps long term.
So I think understanding the pharmacology is really, really important.
Yeah.
And not just having this. I think that's what separates people who have the superficial knowledge of the medications versus really kind of going to that next level of treatment, is understanding the medicinal chemistry, if you will, behind these drugs and which ones play a better role in that particular patient.
Yeah.
I think it's really important. It takes time, takes a lot of effort, but...
And some of it doesn't always make sense. Maybe they act the exact same way and they produce the exact same tangible effect, but long-term outcomes data is different.
Like HCTZ.
You don't always know why.
Yep.
Don't always know why. I did want to mention tranylcypromine was in the step 4 of the STAR-D. That's an MAOI, monoamine oxidase inhibitor. Also one that we would really reserve because of side effects. Hypertensive crisis being one. Tyramine-containing foods can induce a hypertensive crisis.
Cheese.
Like cheese and wine we were talking about before. No cheese if you're on tranylcypromine.
Ugh.
Gosh.
The worst.
That'd be terrible.
But yeah, I think...
maybe good for a lactose-intolerant patient.
Yeah, there you go. But yeah, I think that's a drug class we don't see too often anymore. A lot better options now, but it was still used.
Yeah, it's still used every once in a while.
But yeah, so good stuff.
Got anything else?
No, I think we covered kind of what we set out to do.
Yeah.
5 minutes before.
Did we beat the HCTZ horse to death this episode?
Probably.
And then beat it again and beat it again.
Yeah. It came up because I've had a couple conversations with people recently who basically just told me, well, I don't understand what the point is. Who cares?
Of all the recommendations like in MedRex that I see to make, I feel like HCTZ comes up more than anything else.
Yeah.
I think it's just so ubiquitous. Hypertension is so common that HCTZ comes up all the time.
Mm-hmm. So figured we'd do this podcast and at least discuss it.
Atenolol comes up too. Don't even get us started on atenolol. We'll save that for a different one. Or do you want to talk about
Yeah, we could talk about atenolol very quickly.
It's a similar situation.
Yeah, so real quick, and I have another like flash briefing that's available on iTunes that discusses this. I think it's called like harm with old atenolol.
I think that's what it's called. OL high comma, as some people would call it.
Yeah, if you will.
High comma.
But basically what it showed, it was a big meta-analysis that was done back in, it was Lancet 2004. It had a total of over 17,000 patients in it. And it looked at 9 different trials. The first thing that they looked at was atenolol versus placebo. When they compared all-cause mortality against placebo, there was no difference. Cardiovascular mortality, no difference. MI, no difference. Stroke, no difference compared to placebo. So all those outcomes compared directly to placebo, you might as well just not give them anything. Obviously, we do know that atenolol will lower blood pressure, but you're not stopping the outcome, which is the most important thing. The other thing that they looked at was atenolol versus other antihypertensives, and they saw that in regards to all-cause mortality, they actually had worse outcomes when you were using atenolol versus another agent. Number needed a harm of 111 for all-cause mortality. Wah, wah.
Wah, wah, wah.
And so, it's one of those things that there's not really any good studies. There was the HEP trial.
Not SHEP?
Not SHEP. Well, SHEP used atenolol as well, but SHEP was also started with chlorthalidone.
Right.
But HEP was I think precursor to SHEP, if I remember correctly. And that one did show a little bit of a benefit when you use atenolol, but there's been
Countless
others, and I think the atenolol showed a reduction in stroke. So I think that was the big outcome of that one.
Huh.
But other than that, there's not really any good evidence for atenolol or other beta blockers for that matter used in primary hypertension.
Right. It really is. It used to be used all the time, but now it's really a third line at best these days, if not a fourth line.
And what's odd is like when we think of like combination drugs, atenolol is one of the only drugs in combination with chlorthalidone instead of HCTZ.
Isn't there a combination of like amlodipine and atorvastatin or something like that? How random is that?
What is I cannot think of.
It's not X-Forge, is it? No, that's not what it is.
I can't remember what it is either. But I'm sure we could find it in 2 seconds.
Atenolol went on back order earlier this year, late last year, and I was almost like extremely happy about it. But man, people love their atenolol because they were just freaking out about it. Goodness gracious.
Agreed. Yeah, people were quite upset. Yes.
Caduet or Caduet. I always say Caduet because I like the duet reminds me it's 2 drugs, but Caduet. Okay.
Yes, Caduet has amlodipine and atorvastatin.
Isn't that interesting?
Very strange combination.
I know.
It's treating 2 different disease states in one pill.
Completely different things.
Who would have ever thought it? But
that's America for you. That's how common hypertension and hypercholesterolemia are.
Yeah, unfortunately. But that's definitely something to consider with atenolol because that's another one just like HCTZ. I think it's a drug that people use because they've always used it.
Yeah.
So, yep. And there's definitely going to be people who will argue that and say that we're full of it. But that's okay.
Speaking of that, we've gotten a lot of really good listener mail recently. People emailing in and saying very nice things, which we love. We love when people say very nice things. But I don't think we've heard anything negative yet. So my call out for this podcast is if you have any criticisms or negative things, let us know and we'll, consider them.
Yes.
I'm interested to know. I've been waiting for somebody to just rip us to shreds on something.
Yeah.
But it just hasn't happened yet.
So there's either no one listening for real
right.
or
somebody has to say the nice things. So somebody's out there listening. Apparently nice people.
Yeah. No, I've definitely we've gotten some really cool feedback from people saying they've used our podcasts to help study for boards, all kinds of stuff.
Or binge listening to our podcast. I was like, I can't imagine binge listening to my voice.
Oh my gosh,
horrible.
That would be horrible.
Don't do that. Just do one at a time.
Yeah,
your eardrums will burst.
I can't listen to my own voice for about 15 minutes before I want to turn it off.
I know. That's why I have to interrupt you because I can't stand listening.
I hear you. So yeah, please email us if you guys have any comments, concerns. We would definitely like to hear it, or even just overall suggestions for making everything better. We're always trying to improve not only the quality, but also the content and making sure that we're providing some kind of value for you guys. But yeah, email us, reach out to us on social media, whatever your preferred action of communication is. Smoke signals probably won't reach us very well, so don't do that.
I don't know. That'd be pretty cool.
That would be cool.
Yeah.
I don't know how to read them, though.
I would respond to that. I would at least say, like, hey, what's up?
Yeah.
I see the smoke.
There you go. Hopefully they're local. But, yeah, send us a message, guys. We really appreciate all you listening. The comments that and the ratings that you've been giving us on iTunes help tremendously. Thank you so much for that. And, yeah, let us know what we can do, what topics we can cover that will be most beneficial. And we always appreciate it. Thank you so much. Y'all have a great one and a good rest of your Memorial Day or whenever you happen to be listening to this.
Right, which will probably be posted. Well, I don't know. It might be posted tonight. Who knows?
Yeah, we'll see.
We'll see.
Y'all take it easy. Bye.